Blood pressure is the force exerted by the blood against the walls of blood vessels. Blood flows from high to low pressure areas. In the arteries, the pressure near the heart is very high, which slows down as it reaches the arterioles. The peak pressure in the arteries during the cardiac cycle is known as the systolic pressure, while the lowest pressure at resting phase of the cardiac cycle is called the diastolic pressure. During systole, the artery wall stretches to accommodate the new blood entering the arteries, while during diastole, the walls return to normal due to their elastic properties. Blood pressure is measured in millimeter of mercury, that is mmHg, and it is expressed in two readings, systolic pressure and diastolic pressure. The SI unit for blood pressure is Pascal. For instance, a healthy adult's typically resting value is 120/80, indicating a systolic pressure of 120 mmHg and a diastolic pressure of 80 mmHg. Below the level of 90/60 is low blood pressure and above 140/100 is high blood pressure. There are two responses in blood pressure, a short-term response and a long-term response. The short-term response involves sympathetic activation, which means that the adrenal glands release epinephrine and norepinephrine. This leads to increased cardiac output, which helps maintain blood pressure, and peripheral vasoconstriction, which is the narrowing of blood vessels to raise blood pressure. The long-term response involves the kidney producing renin, which initiates the process. This leads to angiotensin II activation, which results in antidiuretic hormone release, aldosterone secretion, thrust stimulation, and increased red blood cell formation. The ultimate result in this process is increased blood volume, which restores homeostasis. Short-term regulation of blood pressure, rapidly acting within second to minute. They are baroreceptor reflex mechanism, chemoreceptor mechanism, CNS ischemic response mechanism, and atrial stretch volume receptors. Intermediate term regulation of blood pressure, respond from 30 minutes to several hours. They are capillary shift mechanism, stretch relaxation of vessel, and renin-angiotensin system. Long-term regulation of blood pressure, acting within days to months. They are aldosterone mechanism and renal body fluid control mechanism. Short-term regulation of blood pressure, baroreceptor reflex mechanism. The arterial pressure of the body is normally maintained within narrow limits, thanks to a negative feedback reflex called the baroreceptor reflex. This reflex responds rapidly to any deviation from the set point of regulated blood pressure, ensuring that arterial pressure remains within a narrow normal range. Pressure-sensitive receptors located in the aortic arch and carotid sinus provide the afferent component of the baroreceptor reflex, relaying information to the CNS via the 9th and 10th cranial nerves. These afferent impact the activity of cardiovascular autonomic outflow and are projected to the nucleus tractus solitarius, a specific region in the CNS. The central neural pathways connect the baroreceptor afferent signal projecting to the NTS to the preganglionic sympathetic vasomotor neuron in the intermediolateral and vagal cardiomotor neurons. A projection from the NTS to neurons in the caudal ventrolateral medulla mediates the baroreceptor evoked changes in sympathetic preganglionic neurons. These cells in the CVLM provide inhibitory innervation of RVLM neurons that innervate sympathetic preganglionic neurons. The NTS baroreceptive neurons excite vagal preganglionic parasympathetic cardiomotor neuron in the nucleus ambiguous and dorsal motor nucleus, and this input is likely monosynaptic. The neurotransmitter glutamate and GABA play a dominant role in the baroreceptor reflex. Apart from the direct autonomic control of the heart and vasculature, afferent input from arterial baroreceptors also influence other brain inputs that are relevant to cardiovascular regulation. Effector systems of arterial baroreceptor reflexes. The arterial baroreceptor reflex refers to various physiological responses caused by changes in baroreceptor afferent activity. Although the baroreceptor reflex primarily implies the reflexive alteration in arterial blood pressure and heart rate due to changing autonomic outflow to the vasculature and heart, there are many other physiological responses resulting from changes in baroreceptor afferent input. Each of these responses would appropriately be referred to as a baroreceptor reflex. For instance, decreases in arterial blood pressure sensed by arterial baroreceptors cause an increase in vasopressin secretion from the posterior pituitary and an increased thrust as reflected by increased fluid ingestion. Therefore, baroreceptor reflexes can be observed to have autonomic, endocrine and behavioral effectors, all of which collaborate to promote cardiovascular homeostasis. In elevated blood pressure, baroreceptors detect high blood pressure. Cardioacceleratory centers are inhibited. Cardioinhibitory centers are stimulated. Vasomotor centers are inhibited, causing vasodilation. Cardiac output decreases, reducing blood pressure. In reduced blood pressure, baroreceptors detect low blood pressure. Cardioinhibitory centers are inhibited. Cardioacceleratory centers are stimulated. Vasomotor centers are stimulated, causing vasoconstriction. Cardiac output increases, elevating blood pressure. This reflex helps maintain homeostasis. Arterial baroreceptor reflexes role in hemorrhage. In hemorrhage, that is blood loss, blood volume will decrease and therefore venous pressure will decrease, which reduces venous return. Therefore, arterial blood pressure will decrease further and it decreases ventricular end diastolic volume. In result, it decreases in stroke volume. So, cardiac output will decrease, and due to cardiac output decreased and it decreases arterial blood pressure. The chemoreceptor reflex. Chemoreceptors are cells that detect changes in O2, CO2 and hydrogen ion. They have a high blood flow of 1200 ml per minute per gram tissue, which makes it easy for them to detect these changes. If the blood flow reduces due to reduced mean arterial pressure, the chemoreceptors get stimulated through oxygen lack, increased hydrogen ions or carbon dioxide. The response to this stimulation is excitatory and not inhibitory. It mainly occurs through the activation of sympathetic nervous system. They reduce blood flow to unessential area and protect vital tissue like brain and heart. CNS ischemic response. CNS ischemic response operates rapidly to prevent further decrease in mean arterial pressure whenever blood flow to brain decreases. It is one of the most powerful activators of the sympathetic vasoconstrictor system. When mean arterial pressure is less than 20 mmHg, promotes cerebral ischemia of vasomotor center, leads to strong excitation of vasomotor center due to accumulation of carbon dioxide and lactic acid, leads to strong vasoconstriction of blood vessels including the kidney arterioles. Atrial stretch volume receptors. Receptors in large veins close to heart walls of the atria, response of blood volume. An increased blood volume leads to stretch of atria, which leads to activate atrial volume receptors and goes through sensory afferent nerve to medulla, that inhibiting the cardiovascular center. This results into decreased blood volume through decreased sympathetic drive to kidney, which dilate afferent arterioles, which increase a glomerular capillary hydrostatic pressure and increase GFR, that leads to decreased blood volume toward normal. Decreased sympathetic drive to kidney decrease renin secretion. Inhibition of renin secretion leads to inhibits aldosterone production, which decrease blood volume toward normal. Decrease ADH secretion, which further decrease blood volume toward normal. Increase atrial natriuretic peptide ANP causes loss of blood volume. Intermediate term regulation of blood pressure. Capillary shift mechanism. Movement of fluid from interstitial spaces into capillaries in response to decreased blood pressure to maintain blood volume. Conversely, when capillary pressure increases too high, fluid is lost out of the circulation into the tissue, reducing blood volume as well as all pressures throughout circulation. Stretch, relaxation of vessel. Blood vessel smooth muscle respond to changes in blood volume. When pressure in blood vessels is too high, vessels stretch and stretch more and more for minutes or hours, resulting in decreased blood pressure in vessels toward normal. The continuing stretch response of vessel can serve as an intermediate term pressure buffer. Renin-angiotensin system. Kidney. When blood pressure drops, the kidney releases renin. Liver. Renin converts angiotensinogen from the liver into angiotensin 1. Lungs. Angiotensin 1 is converted into angiotensin 2 with the help of an enzyme, that is, angiotensin converting enzyme. Effects: vasoconstriction. Angiotensin 2 causes blood vessels to constrict, elevating blood pressure. Thrust and drinking. Angiotensin 2 stimulates the hypothalamus, leading to thrust and increased fluid intake. Remember, this process helps maintain blood pressure within a healthy range. Long-term regulation of blood pressure, acting within days to months. The renin-angiotensin-aldosterone system. Aldosterone. Angiotensin 2 triggers the adrenal cortex to release aldosterone, promoting salt and water retention in the kidneys, further increasing blood pressure. Renin release. The renin-angiotensin-aldosterone system is a hormone system within the body that is essential for the regulation of blood pressure and fluid balance. The system is mainly comprised of the three hormones, renin, angiotensin 2 and aldosterone. Primarily, it is regulated by the rate of renal blood flow. The first stage of RAS is the release of enzyme renin. When renal blood flow is reduced, juxtaglomerular cells in the kidney convert the precursor prorenin, which is already present in the blood, into renin and secrete it directly into the circulation. Renin released from granular cell of the renal juxtaglomerular apparatus in response to one of the three factors. First, reduced sodium delivery to the distal convoluted tubule was detected by macula densa cells. Second, reduced perfusion pressure in the kidney is detected by baroreceptor in the afferent arteriole. Or third, sympathetic stimulation of JGA via beta-1 adrenoreceptors. The release of renin is inhibited by atrial natriuretic peptide, which is released by stressed atria in response to increases in blood pressure. Production of angiotensin 2. Angiotensinogen is a precursor protein produced in the liver and cleaved by renin to form angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 by angiotensin converting enzyme. This conversion occurs mainly in the lungs where ACE is produced by vascular endothelial cells, although ACE is also generated in smaller quantities within the renal endothelium. Binding of angiotensin 2. Angiotensin 2 exerts its action by binding to various receptors throughout the body. It binds to one of two G protein coupled receptors, the AT1 and AT2 receptors. Most action occur via the AT1 receptor. Effect of angiotensin 2. Cardiovascular effect. Angiotensin 2 acts on AT1 receptors found in the endothelium of arterioles throughout the circulation to achieve vasoconstriction. This signaling occurs via a GQ protein to activate phospholipase C and subsequently increase intracellular calcium. The net effect of this is an increase in total peripheral resistance and consequently blood pressure. Neural effect. Angiotensin 2 acts at the hypothalamus to stimulate the sensation of thrust, increasing fluid consumption. This helps to raise the circulating volume and in turn blood pressure. It also increases the secretion of ADH from the posterior pituitary gland, resulting in the production of more concentrated urine to reduce the loss of fluid from urination. This allows the circulating volume to be better maintained until more fluids can be consumed. It also stimulates the sympathetic nervous system to increase the release of noradrenaline. This hormone is typically associated with the fight or flight response in stressful situations and has a variety of actions that are relevant to the RAS. They are increase in cardiac output, vasoconstriction of arterioles, and release of renin. Renal effect. Angiotensin 2 acts on the kidneys to produce a variety of effects, including afferent and efferent arteriole constriction and increased sodium ion reabsorption in the proximal convoluted tubule. Angiotensin 2 is also an important factor in tubuloglomerular feedback, which helps to maintain a stable glomerular filtration rate. The local release of prostaglandins, which results in preferential vasodilation of the afferent arteriole in the glomerulus, is also vital to this process. Finally, angiotensin 2 acts on adrenal cortex to stimulate the release of aldosterone. Aldosterone is mineralocorticoid, a steroid hormone released from the zona glomerulosa of the adrenal cortex. Aldosterone acts on the principal cells of the collecting ducts in the nephron. It increases the expression of apical epithelial sodium ion channel (ENaC) to reabsorb urinary sodium. Furthermore, the activity of the basolateral sodium-potassium ATPase is increased. This causes the additional sodium reabsorption through ENaC to be pumped into the blood by the sodium-potassium pump. In exchange, potassium is moved from the blood into the principal cell of the nephron. This potassium then exits the cell into the renal tubule to be excreted into the urine. As a result, increased level of aldosterone causes reduced level of potassium in the blood. Renal body fluid control mechanism. Increased extracellular fluid volume leads to increased blood volume, will increase mean circulatory filling pressure, that increased venous return of blood to the heart, and increased cardiac output, which increase arterial pressure. Increased cardiac output also go through autoregulation, which increase total peripheral resistance and then increase arterial pressure. Blood osmolality also affect arterial blood pressure, and through renal body fluid control mechanism it will reduce. Increased blood osmolality leads to osmoreceptors in the hypothalamus. Hypothalamus act via posterior pituitary and thrust mechanism. Posterior pituitary increase ADH, which retain water by kidney. Thrust increase drinking of water, which increase blood volume and decrease osmolality. Decreased blood osmolality also goes through negative feedback responses. Clinical significance. Overactivation of the renin-angiotensin-aldosterone system has been implicated in the pathogenesis of various cardiovascular and renal disease. RAS is also implicated in the pathogenesis of primary hypertension. This has been proven by using medication that block the RAS at different steps. Overactivation of RAS is also implicated in the development of secondary hypertension due to primary hyperaldosteronism. Primary hyperaldosteronism is the excess aldosterone production either by an adrenal adenoma, Conn syndrome, or bilateral adrenal hyperplasia, producing excess aldosterone. These patients have suppressed renin and elevated aldosterone level, often with hypokalemia. Primary hyperaldosteronism remains an under-recognized condition with excess cardiovascular and renal morbidity and mortality. All patients with resistance hypertension should be screened for this condition for early diagnosis. Early diagnosis and timely management can lead to improved outcomes.